COVID-19 has impacted people in a very inequitable way. Racialized and marginalized people have been hit hardest. Our foundation, the Vorha Miller Family Foundation, has partnered with the Dalla School of Public Health to launch the Institute for Pandemics. The Institute for Pandemics takes a holistic view of the pandemic, focusing not just on the current crisis, but also on resilience and recovery using health equity lens as a key driver. The greatest strength of the Institute is the intersectionality that is built from the ground up. We will be liaising with epidemiologists, infectious diseases, health systems, policy, economics, bioethics, and many more. The road to recovery is going to be long and hard, but it must be done in an equitable way. We absolutely cannot leave anyone behind.
Good afternoon and a very warm welcome to the inaugural lecture of the Vahora Miller Lectures on Critical Public Health Issues under the umbrella of the Dalla School of Public Health's Institute for Pandemics. The Institute for Pandemics aims to better understand pandemics both before they arise and while they are progressing. It aims to strengthen our public health systems, improve how they are governed, and plan how we might best structure health systems and recover economically in a post-pandemic world. This lecture series, among others, is such as student and faculty support for key work in pandemic research, has been generously supported by the lead donor of the Institute for Pandemics, the Vorha Miller Foundation, and we thank Sabina Vorha Miller for her passion and engagement in these issues. Today's discussion will focus on racial health inequities in COVID-19 impact and outcomes. Before we start, we wish to acknowledge the land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and most recently, the Mississaugas of the Credit River. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. Our program today will include a keynote address from Dr. Nancy Krieger, followed by reflections from each of our two respondents, Ms. Camille Orridge and Mr. Joe Cressy. We will then move to a discussion between our keynote speaker and respondents, and then to questions from you, the audience. Attendees can ask questions via the Zoom Q&A, and a few will be selected by our team and read to our panel by me. This event will be recorded and posted on the Dalla School of Public Health YouTube page following the event with closed captions. All audience microphones and cameras will be turned off for the duration of the event. And now it is my distinct pleasure and privilege to introduce to you our three panelists. Full biographies and a reading list kindly provided by Dr. Krieger that contains articles relevant to her talk are available in the chat of this Zoom. We'll also be adding some articles that Ms. Orridge passed along that are underpin her talk as well. So our keynote speaker is Dr. Nancy Krieger, who is professor of social epidemiology at the Harvard T.H. Chan School of Public Health. It is well worth reading her bio, but as many of you know, Dr. Krieger is one of the most prolific and influential public health scholars of our time, and we are honored and delighted that she is joining us today. Our respondents are Camille Orridge and Joe Cressy. Ms. Camille Orridge is a senior fellow at the Wellesley Institute and a professor at the Dalla School of Public Health. She is a longtime healthcare administrator and more generally has worked tirelessly on issues of health equity in Toronto. Joe Cressy is chair of the Toronto Board of Health and counselor for Toronto's Ward 10, Spadina Fort York. During the current COVID-19 pandemic, Councilman Cressy has been very active in the discourses about COVID health equity. We are really fortunate today to be able to talk to and hear from these three people who bring different perspectives to bear on the issues of race, racism, and COVID-19. So without further ado, I'm happy to hand the microphone over to Dr. Nancy Krieger. Nancy?
So thank you for including me today. In my half-hour presentation, I will speak on the issue of structural racism, embodied histories, and COVID-19 in context, lessons from the United States. I begin, as I do for all my talks, by acknowledging that as a US person in Boston, Massachusetts, I am on Indigenous lands and I pay heed to critical Indigenous thinking. And I also speak at a time of continued outrage, grief, and social mobilization over structural racism, police killings, assaults on democratic rule, all profoundly intertwined with COVID-19. My three key points are first, that there are terrible inequities reflecting structural racism and societal injustice and who is being exposed to the virus that causes COVID-19 on account of working and living conditions. And these inequities can and should be prevented. At issue is who can versus cannot afford to work from home, let alone has a home, and if they do have space to self-isolate if infected, and if an essential worker who does versus does not have safe working conditions, paid leave, and adequate personal protective equipment, and protection by government regulations against exposure. Second, there are terrible inequities in who is more likely to die if infected, reflecting pre-existing social, economic, and contingent health inequities. And third, in the US, there are terrible problems in how the data are being reported by public health agencies, which make it hard to see, contextualize, and address these inequities. Remember, as you look at these data for the US, taken from the Hopkins website the other day from November 22nd, which shows that the US continues to regrettably lead the world in case and death counts, every tested person, every one of the 12.1 million confirmed cases, has worried about what will happen, as have families and friends. Every one of the now over 255,000 deaths listed as COVID-19 deaths have families, networks, and neighborhoods who are grieving, translating to millions affected. And only after considerable hue and cry, led by anti-racist organizations and their allies, did the CDC, the Centers for Disease Control, release data on race, ethnicity, and COVID-19, which show that the age-standardized rates of hospitalization and mortality are 3 to 4 times higher in the US among non-Hispanic, Black, Latinx, and Indigenous versus the non-Hispanic white population. With our new work showing that much larger racial ethnic inequities and mortality occur among working age adults, limiting interpretation, the CDC has failed to include data on occupation, income, education, disability, sexual orientation or gender identity, or incarceration status, let alone data on societal or community context. The starting point to discuss these data must be a science of racism. The point of analyzing scientifically how racism harms health is not to prove that injustice is wrong, because it is, by definition, nor is the point to do quote unquote politically correct science. Rather, the point is to do correct science, to generate publicly testable and tested knowledge that provides insights for rectifying and understanding who is bearing the burden of exposure, disease, and death, and to ascertain if these distributions are inequitable, whereby health inequities refer to differences in the distribution of health outcomes across social groups that are unjust, avoidable, and in principle preventable. How then to account for the terrible data on COVID-19? Theory is key. On this slide, I show the overall framework of the Ecosocial Theory of disease distribution, which I first proposed in 1994 and have elaborated since. And I also show its direct application to analysis of racism in health, concern with levels, pathways, and power, and also time in relation to both individual life course and historical generation. Ecosocial theory seeks to explain population distributions of health. A central focus is on embodiment, referring to how we literally incorporate biologically our societal and ecological context, thereby producing population patterns of health and health inequities. The theory clarifies that there is not just one pathway by which structural racism harms health, there are many, including economic and social deprivation, excess exposures to toxins, hazards, and pathogens, social trauma, health-harming responses to discrimination, targeted marketing of harmful commodities, inadequate medical care, and both ecosystem degradation and alienation from the land, especially but not only for Indigenous people. The ecosocial constructs of agency and accountability further clarify that racism, not quote unquote race, is what's causally at issue. And what matters is who benefits from, not just who is harmed by, structural racism, and thus where white supremacy fits into the picture. This tracing of causal arrows from racism to embodying injustice to health inequities is thus diametrically opposed to the dominant view, which draws the arrows from quote unquote race, construed as biologically distinct groups, to racial differences in health status and culture, as if the problem were alleged biological and cultural inferiority, rather than privations imposed by the privileged to protect their wealth and status. Reckoning with health inequities requires reckoning with embodied histories, including those of structural racism. Grappling with embodiment is core to the science of racism. Here, consider the words of Claudia Rankine, an African-American poet who in her award-winning prose poem, Citizen, an American Lyric, wrote, quote, The world is wrong. You can't put the past behind you. It's buried in you. It's turned your flesh into its own cupboard. Not everything remembered is useful, but it all comes from the world to be stored in you, end quote. The image from the New Zealand Māori presentation on historical intergenerational trauma tells a similar story, literally rooted in settler colonialism and racism, with the trunk containing the political and social mechanisms at play, and the branches and leaves expressing the resultant adverse outcomes, including but not limited to health status. Roots, however, are also key to endurance and growth, and new Indigenous and African American histories and activism emphasize renewal, continued resistance, resilience, and strength in the face of daunting odds, drawing on history to imagine and advocate for a more equitable and sustainable world. The science of racism also requires reckoning with who wields the two-edged sword of data. A crucial first point is that data, contrary to its etymology, is never a quote-unquote given. Despite being the past participle of the Latin verb dare, to give, data are always produced by people out of what they observe or fail to see in the world and universe in which we live. A key sticking point to remember is that privilege always is defined in part by what you can afford to ignore. One accordingly must always ask, who produces and controls the data, to what end, and engaging with what history? From the standpoint of the US, the histories of contested production and use of racialized data extend back to the origins as a slave republic and settler colonial nation. In the 18th century CE, these data were largely produced and used by the enfranchised minority of white men with property to entrench injustice, to characterize who was enslaved versus free, and which indigenous tribes and nations were versus were not under colonial and then later federal jurisdiction. Indeed, these data comprised a core part of the first ever decennial census in 1790, which was also the first ever census to be constitutionally mandated by a government anywhere, with a count key to apportionment of political representation, allocation of resources, and power. If any of you follow the US news, the same is true now. In the 19th century CE, starting with the rise of the abolition movement, a shift in the use of the data is discernible. Thus, abolitionists, including the first generation of credentialed African American physicians, began using racial ethnic data, including on health status, to challenge the abominations of slavery, while supporters of slavery, including many physicians and scientists who embraced scientific racism, sought to use the same data to uphold the doctrine of white supremacy. Then as now, debates turned on whether the racial ethnic categories were constructed by people with purpose in mind versus so-called natural categories, reflecting innate or a priori differences. The crux of the argument for health was whether racism versus quote unquote race accounted for observed differences in health status across racialized groups. In the early 20th century CE, the same sorts of schisms existed, updated vis-a-vis challenging versus upholding Jim Crow, which refers to the system of legal racial segregation and white supremacy that was enacted in the 1880s, fueled by white backlash to the defeat of slavery in the Civil War and also the civil rights gains during the Reconstruction, and enforced by terror. It was also played out in the concomitant challenges to versus supportive eugenics in the 1920s, particularly with the latter strongly upheld by the US Supreme Court and leading scientists, university presidents, and more. And they ushered in the passage of eugenic sterilization laws in 32 US states, and also eugenic fostered federal immigration restriction acts of 1924 and 27. Subsequently, during the 1950s and 60s, racial ethnic data featured prominently in fights for and against civil rights and for and against overturning the eugenic era immigration restrictions. In the wake of major legislation passed in 1965, which afforded new protections of civil rights and also expanded immigration, official government racial ethnic data started to be used to provide evidence of injustice as opposed to justifying it. However, the successful civil rights strategy of using racial ethnic data to demonstrate the existence of what is called in the US, quote unquote, statistical discrimination or quote unquote, disparate impact, and to guide resource allocation to address this issue, sparked, unsurprisingly, a conservative backlash, leading to two types of resistance. One was to try to suppress collection or reporting of racial ethnic data, thereby removing any evidence of harm requiring redress. The other, in legal cases, was to require evidence of motivation, not just disparate impact. Hence the two-edged sword of data in terms of race ethnicity. In the context of a society whose history is deeply bound up with structural racism, not to have any racial ethnic data, usually couched as a quote unquote colorblind approach, means you end up with the problem of no data, no problem, and the denial of and thwarting of any ability to prove that the problem exists, hence edge number 1 of the sword. However, edge number 2 of the sword is that problematic data, whether wrongly conceived, wrongly used, or both, can be a really big problem, as evidenced by reams of US health reports and research which use racial ethnic data but include no data on racism and continue to treat racial ethnic health inequities as primarily driven by alleged genetic differences, individual behaviors, or deficient cultural mores. Nor is this two-edged sword unique to the US. It is relevant to any country with social inequities involving racialized groups, as attested to by related controversies over the collection and use of racial ethnic data in a wide array of countries, including France, Portugal, Brazil, Mexico, the UK, Australia, New Zealand, Canada, the list goes on. And in the midst of this tension, keep in mind the actual point, which is what role can data play or not in efforts to secure health justice? What does all this have to do with COVID-19? First, it's essential to be clear that COVID hit a world already riven by inequities. This slide shows all too familiar data which critically situate the context of the COVID-19 pandemic. We live in a world of growing social spatial polarization with ever greater concentrations of private wealth, as epitomized by the factoid that in 2018, 26 persons in the world owned as much wealth as the poorest half of humanity, down from 43 in 2017. In the US, where the top 1% owns a greater share of wealth than their 1% counterparts in various European countries, 3 men now own as much wealth as the bottom 50% of the US population. Enormous wealth gaps by race ethnicity are on the rise. Intergenerational economic mobility is on the skids. And at the bottom of the slide, consider these data from the US Census Household Pulse Survey, designed to measure the economic, social, and health impacts of COVID-19. Both before and after COVID hit, that is looking at mid-March, mid-June, and now early November, Black and Latinx households with children were 2 to 3 times more likely than their white non-Hispanic counterparts to report they sometimes or often do not have enough food to eat. Moreover, in early November, among renters, 33% of Black, 42% of Latinx, and 26% of white non-Hispanic households had slight or no confidence that they could pay next month's rent, and 44 to 55% of the Black and Latinx and 21% of the white non-Hispanic renter households fear eviction. Let that data sit with you. About half of all Black and Latinx renters are now worried about eviction, and the moratoria against evictions are running out. Meanwhile, in early October, quote, a report by a Swiss bank, UBS, found that billionaires increased their wealth by more than a quarter, 27.5%, at the height of the crisis from April to July, and quote, with Jeff Bezos, the founder and chief executive of Amazon, adding another 74 billion to his 189 billion fortune, which makes him the world's richest person. And globally, among the world's 2.2 billionaires as of October 6, only 200 have publicly committed 7.2 billion in pandemic assistance, a mere 1/10 of Bezos' extra income alone. But during the first terrible months of the pandemic in the US, you could not find data on COVID-19 and socioeconomic position, and barely any on race ethnicity in US Health Agency reports, despite race ethnicity being a standard variable for just about every other health outcome. Instead, in this early period, so crucial for understanding and altering the course of the pandemic, most of the US data on COVID-19 and health inequities were generated by journalists, as shown by this pastiche of articles I've been collecting since the start of the pandemic. Reminiscent of how the Guardian newspaper set up the Counted in 2015 to 2016 to tally US police killings, given fundamentally flawed official data, with my research team showing that over half of these deaths are not counted in US vital statistics. It was journalists with The Atlantic who set up the COVID-19 tracker, including a race tracker, to augment data not being reported by the CDC. The New York Times and the Washington Post have been leading with data visualizations about the social and spatial distributions of COVID-19 in the US. And as remarked by an historian colleague when she saw this map in the New York Times regarding chronic disease and COVID-19 susceptibility, quote, aside from West Virginia, it looks like a map of slaveholding in 1861. You could say the same for this map of US lynchings. Turning now to the value of scientific theory and the stories that bodies tell, our team was the first to produce data in early April on COVID-19 death rates for all US counties in relation to key social metrics as guided by our integrative multi-level theory. Our four contextual measures pertain to the percent below poverty, percent crowded households, percent population of color, and the extent of racialized economic segregation using a novel measure that I developed building on Massey's index of concentration at the extremes. For the first three, you can see that the highest death rates for COVID-19 occurred in counties with the highest poverty rates, highest crowded housing, and highest proportion of populations of color. However, for the measure for racialized economic segregation, a U-shaped curve is apparent, reflecting, we believe, how the pandemic initially struck those affluent enough to be international travelers and then became entrenched through community spread in communities replete with low-income essential workers and crowded housing. These are systemic problems structured by social injustice. Here too, I also want to emphasize that the measures we employed in this study are not simply quote unquote proxy measures or so-called quote unquote ecologic measures that are a stand-in somehow for individual characteristics. They are contextual measures telling you precisely about the context and communities hit hardest by COVID. Building on this study, we then sought to investigate inequities in the mortality surge tied to the pandemic, and again presented in early May the first US data to examine this in relation to social metrics. For this study, we compared the total mortality rate, that is the number of deaths per 100,000 persons per 2-week period, to the mortality rate for the same 2-week period based on the average for the past 5 years from 2015 to 2019. The value of this approach is that it captures all excess deaths, both those classified as COVID-19 and those that should have been attributed to COVID-19 but were misclassified. For example, because of lack of adequate COVID-19 testing, along with deaths due to the pandemic, but not the infection. For example, deaths from heart attacks among people who avoided going to the hospital because they were fearful of infection. And this approach also takes into account the background seasonal fluctuations and causes of death. Using this approach, we computed the excess deaths for every city and town in Massachusetts, also every zip code, which we characterize in relation to their social and economic composition. To illustrate in this slide, I show our updated analyses from our article just published in mid-October of two of our variables, the index of concentration at the extremes for racialized economic segregation, whereby a value of -1 means 100% of the households are low income and of color, and a value of 1 means 100% of the households are high income, white, non-Hispanic. And also we show percent of crowded households. The data for 2015 to 2019 are adjacent to the 2020 data, and the lines show the groups ranging from low to high for each variable. And no matter which measure we used, all four social metrics show the same terrible social facts, albeit most acutely for the racialized economic segregation. The death rate surged much higher among communities that bear the brunt of racial, ethnic, and economic injustice, including lack of access to affordable housing, lack of a living wage, and histories of racial residential segregation. While the patterns we revealed may not be surprising, our study was the first to show inequities in the surge of excess deaths, and in a US context, it is still essential to document these inequities as evidence necessary to inform COVID-19 interventions and policies and funding. Notably, our study, which we conducted in collaboration with the newspaper, the Boston Globe, enabled the reporters to do important investigative reporting on some hard-hit communities that we identified in our study, but which had not yet had public coverage of their hardship. This reporting helped galvanize public health action and public awareness in these communities, putting their experiences and needs in context and aiding their efforts to get the resources they needed. Underscoring the patterns that we identified, new research is showing that workplaces are key sites of infection, and also that it is household crowding, not population density, that further drives community spread. These are the data needed to guide action and allocation of resources to address the structural determinants of COVID-19 inequities. In additional work using national age-specific mortality rates stratified by race ethnicity, we've also shown that the rate ratios for racial ethnic inequities are greatest among working age adults. The first row shows the age-specific mortality rates per 100,000 person years, starting with ages 0 to 4 and then 10 years age bands up to 55 to 64. And the second row shows the age-specific rate ratios, where green shows the data for the Black non-Hispanic population, blue the American Indian Alaska Native population, purple the Hispanic population, dark orange the Asian and Pacific Islander population, and yellow the white non-Hispanic population. If you look at the size of the rate ratios in the second row, you will see that among working age adults, they reach up to 10 or higher and are persisting over time. I ask you how often you have seen a rate ratio of 10 or more for racial ethnic inequities and health outcome, and the short answer is very rarely. However, despite and reflective of this context, Consider the very problematic ways the CDC initially reported racial ethnic inequities in COVID-19, and in some ways the problems have gotten worse. When pressed by several prominent progressive BIPOC, the terminology used in the US now, Black, Indigenous, people of color, organizations and politicians to start reporting racial ethnic data in April because no such data had been reported yet, the CDC opted to focus on differences in the racial ethnic composition of deaths, of COVID deaths versus that of the total population. Initially, the data for the deaths was on one website and the data for the total population was on another website entirely, making it quite a chore to figure out if the proportions differed. But worse, the data made no sense because contrary to the reports coming from the field, the CDC's data were suggesting that white non-Hispanics were overrepresented among the COVID-19 deaths and Black Americans were underrepresented. Working with some doctoral students to figure out what was awry, we realized that the CDC had committed a classic type 3 error, the right answer to the wrong question. In brief, the CDC weighted the denominators for the US counties by the percent of total COVID-19 deaths occurring within that county within the state. Given who was hardest hit by COVID-19, the net effect was to deflate the denominators for the white non-Hispanic population and inflate the denominators for the other populations of color, thus inflating the risk for the former and deflating the risk for the latter. Why did the CDC do this? The stated reason is that they were concerned that the racial ethnic composition of places initially hit hard by COVID-19, especially New York City, differed from that of areas less hit hard. And they said that they sought to quote unquote correct for this by this weighting procedure. But to ask and answer the question, how does racial ethnic risk for COVID-19 mortality vary apart from how racial segregation affects who lives where, is to ask and answer entirely the wrong question. By treating place and the lived experiences and impacts of residential segregation as nuisance factors to be quote unquote corrected for by weighting, the CDC reached the entirely wrong conclusion. Partly because of the criticisms raised, including by our team, the CDC revamped its approach and for a brief while this summer showed results based on both the weighted and unweighted population data, plus also included the racial ethnic composition of the total population in the same table. But since early fall, the CDC data on race, ethnicity, and COVID-19 have become even less informative. This latest snapshot from November 21st shows simply proportions based on counts with no data on population composition. Instead, the text cryptically states, these data, quote, these data only represent the geographic areas that contributed data on race ethnicity. Every geographic area has a different racial and ethnic composition. These data are not generalizable to the entire US population. If cases were distributed equally across racial and ethnic populations, one would expect to see more cases in those populations that are more highly represented in the geographic areas that contributed data, end quote. Now, if you're a trained data analyst, or perhaps a Talmudic scholar, you might be able to parse the meaning of what that says, which is that the racial ethnic composition of cases has something to do with both the racial ethnic composition of where cases are occurring and also the risk by race ethnicity for being a case. But good luck with figuring that out for the text, or starting with the assumption that all racial ethnic groups in the US have equal risk, which is patently false. And the case data still have high levels of missingness. Here I note that a new federal regulation enacted on June 4th notably mandated the reporting of racial, ethnic, and other demographic data for COVID-19 cases, and this reporting was to be in effect by no later than August 1st, 2020. In mid-September, we checked, and on September 18th, we released a new working paper now published in The Lancet, which demonstrated that this is not occurring. Specifically, race ethnicity was missing for fully 43% of the new COVID-19 cases added to the CDC roster between August 28th and September 16th. This is not encouraging. And bad, if not worse, what scant data the CDC had begun to post on COVID-19 in correctional facilities earlier this year is now completely gone. If you go to the website, there's a heading for it, but it is completely blank, as shown on this slide. Just this past Sunday, however, the New York Times editorial board issued a scathing editorial titled, quote, "America is letting coronavirus rage through prisons. It's both a moral failure and a public health one," end quote. For evidence, it had to cite the data from the Marshall Project, which is a nonprofit project launched by independent journalists to document the toll, currently at over 197,000 cases and 1,450 deaths. At this point, given growing documentation of political interference in the workings of the CDC, it is reasonable to infer that these data gaps constitute pernicious cases of the no data, no problem approach. This is my last slide of data, and it shows how lack of attention to context, specifically work and what workers have to say about work, is lethal. What we show here are a novel analysis of the worker complaint data to OSHA, the Occupational Safety and Health Administration, which is yet to implement any COVID-19 standards and which has also enormously reduced the number of inspections that they carry out. What stands out is that rises in complaints, which are shown by the vertical bars with blue with the workers in healthcare and other social assistance occupations, purple for the real-tier workers, orange for the workers in manufacturing, and tan for the rest, resemble an epidemic curve with the mortality rate shown by the black line following in kind. The bottom half shows the heat map that we made of correlations between the complaints and mortality rates, and also cases, and demonstrate that the strongest correlation occurred for deaths 16 days after the complaints with an R equal to 0.83. The power of this finding is that we demonstrate the temporal order. It was not as if workers became aware of rising death rates and started complaining at work. Instead, workers complained first and the deaths followed, with an unsurprising lag of a little over 2 weeks, given incubation period and time to manifestation of legal symptoms. Yet if you try to find data on occupational hazards and COVID-19 at the CDC website, good luck. There's only one bit of data on healthcare providers, zero discussion of how in the US, the vast majority of so-called essential workers, especially in grocery stores, bus drivers, warehouse workers, and meatpacking plants, or migrant agricultural laborers, are disproportionately low-wage workers of color who lack physical and social protections at work with little to no sick pay. Ignoring or suppressing these data does not make these problems go away. It just makes it harder for those organizing for health justice to press their case in both courts of law and in the court of public opinion. You'll be hearing more about action steps for health equity that are relevant to Canada from the other speakers. So here, just let me flag the headlines for us in the US, who are in the midst of conveying this message to the Biden-Harris COVID-19 task force that is part of their transition team. First, we need better data to inform action so as to prevent transmission, and then also mitigate the economic and social harms due to inequitable policy responses to this pandemic. Back in early April, in an interview with The New Yorker, I commented that COVID-19 is pulling the thread, revealing both profound connections and profound divisions within the US, and also within and between countries worldwide. As people, as Homo sapiens, we are all potentially at risk of COVID-19 infection, but this risk is profoundly and inequitably socially structured. Ditto for climate change. When I think of pulling the thread, in my mind's eye, I see two images at once: the glorious patchwork quilt that is our planet, and the quilt that Jesse Jackson memorably spoke of in his famous 1988 speech at the Democratic National Convention. At that time, I was serving as a member of his National Rainbow Coalition National Health Commission, for which I wrote the AIDS platform. In this speech, Jackson declared, quote, "Common ground. America is not a blanket woven from one thread, one color, one cloth. When I was a child growing up in Greenville, South Carolina, my grandmama could not afford a blanket. She did not complain, and we did not freeze. Instead, she took pieces of old cloth, patches, wool, silk, garbardine, crocker sack, only patches, barely good enough to wipe off your shoes with. But they didn't stay that way very long. With sturdy hands and a strong cord, she sewed them together into a quilt, a thing of beauty and power and culture. Now we must build such a quilt." He went on to talk about the patches so many occupied, none big enough for their needs, whether farmers, workers, women, students, Blacks, Hispanics, gays, and lesbians, invoking their fights for fair prices, fair wages, comparable pay, Head Start and daycare and prenatal care, jail care, welfare, scholarship, civil rights, and a cure for AIDS. To each he said, quote, "Your patch is not big enough," end quote, followed by, "But don't despair. Be as wise as my grandmama. Pull the patches and the pieces together, bound by a common thread. When we form a great quilt of unity and common ground, we'll have the power to bring about healthcare and housing and jobs and education and hope for our nation," end quote. Can we not today strengthen the threads that keep this quilt intact rather than tear at its very seams? And yet, despite decades of research on social determinants of health and rising awareness of the needs for policies to address structural racism. Here we are in the US in the COVID-19 pandemic in the midst of a horrific fall surge countrywide that was predicted from the outset if spread was not curtailed. And throughout the course of this now lame duck administration, officially so, health inequities have been at best an afterthought or perhaps an unpleasant surprise or worse, data to be suppressed. For those of us in public health, our job, our professional responsibility is to say enough and to generate, working with the social movements for racial justice and health justice, the kinds of data that they need and that health agencies should report truthfully to reveal the terrible embodied truths of this pandemic and bolster the fight for health equity. In closing, we live and die embodied. It is long past time for our science to integrate levels and timescales of embodiment from structural injustice to submolecular levels across historical generations, with an eye to revealing what it means to embody dignity, equity, and joy. In public health, we have a critical duty of counting for accountability. Translated to the US context, it is essential to monitor correctly, not like what we have had, the total and inequitable burdens of exposure and adverse health outcomes. So that all the different sectors, government, private, and civil society, can know who is most harmed and who is responsible, and in many cases, benefiting from these inequities. Only with such embodied truths, backed by the possibilities of lawsuits, legal accountability, and social movements organizing for social justice and changes in policies and regulations, do we in the US stand any hope of making headway on the twin tasks of protecting the people's health and advancing health equity. As for other countries, it is up for the people of each nation, cognizant of their own histories of social injustice, to determine what data and data protocols best suit their needs to advance health justice. And no matter what country we are in, let us do our work, including for COVID-19 and health justice, informed by history and a vision premised on social justice and human rights, along with deep recognition of our interconnection with and dependence on our wondrous and threatened planet. Let us also always remember that data never speak for themselves. They are produced, interpreted, and replicated or contested by people in the course of doing and engaging with science. And may George Floyd, Ahmaud Arbery, Breonna Taylor, and so many more whose lives are cut short by police violence rest in justice, and may the families and friends of all who have died from COVID-19 join with them in grief, with the energy of youth rising for a more equitable and sustainable future, help repair this world. Thank you.
Nancy, I can't thank you enough for that presentation and for sharing so much of yourself with us and your work. Camille, we will now turn to you for your comments.
It's a pleasure to participate on this panel today. I must say, a week ago, I was concerned that I wouldn't have anything to add, particularly following you, Nancy. I thought, what could I possibly have to say? And then I came across this article sent to me by a friend, Malcolm, and the title is Bridging COVID-19's Racial Divide. And it's by Amanda Brimner and 5 others. It's actually from the Boston Consulting Group, which, as I read that article, I kind of rethought a whole pile of stuff, and it took me back to my own life and my own history. And I thought I would just spend some time going through that, because so 40 to 50 years ago, I was a personal assistant here in Toronto. In today's days, that would be COVID exposure number 1, just by being a personal assistant. What that would mean is and at the time I had multiple jobs in order to make a living. There's no one job gave me sick pay, no one job gave me enough hours. I refer to that then as exposure number 2. I lived in a house with my family because there were no affordable housing around. So in order for us to live, we lived together. I lived with my mom. She worked at night with the Salvation Army Women's Shelter, which then would be exposure number 3 today for COVID. And all of this is 40 years ago. So as I looked at 40 years ago and today, there's actually very little difference. Um, my brother and his wife lived with us. My brother worked in a factory, exposure number 4. His wife worked in a factory, exposure number 5. My sisters were in school, exposure, COVID exposure number 6. My child was in daycare, COVID exposure. We all took transit, another set of exposures. My siblings were in high school, another set of exposure. So just by living and working, there are all those exposures. So as we talk about COVID, and I hear people talk about communities and how people live in communities, and I see public health data that talk about communities that drive me crazy because it doesn't talk about the exposures that these people have just by living day to day. And it's not genetics, it's not the geography that give them COVID, it is all these exposures. And I use personal assistant because that's my own personal experience, but this goes to all the essential workers. This is not significantly different. So, that was 40 years ago. It's not any different today. Black and brown people, we just work. I am now enthralled because it now has a name. And it now has a name because white kids graduating from university are in the same boat. So the name now is precarious work. Well, we've always done precarious work. And I'm thrilled it has a name now. I'm thrilled that people are probably looking at it and may come to some solutions. But precarious work is the underpinning of what we're talking about COVID, but we very rarely talk about it in those terms. So far, in terms of COVID, nothing here is new. Nothing was not known. The data is an issue. Toronto, Ontario, Canada has not collected this data and has actually been actively resistant to it. US and England have collected the data, and we can complain about the fact that they have not used it, but at least they had some of it. And we need to go forward. And I really like the double-edged sword, Nancy, because that's the debate we're having here in Toronto with among academia and ourselves. Do you collect the data, not collect the data? I'm of the opinion that we need to collect the data and we need to put governance over it to reduce some of the barriers we now expect. But so far, the data has not told us anything we didn't know, at least those of us who have lived in those spaces. So the impact of all of this for me is what I refer to as culling. And what we're experiencing now and the culling we're experiencing now is the impact of years of bad decision or indecision. We knew and learned from SARS and H1N1 what happened. We knew about this workforce, we knew about essential workers, we knew about their exposures, we knew about that, but nothing really happened. So for us to talk about a pandemic and future pandemics, testing and all of that, I think all of that has to be done, but for me, it really still doesn't go to the core. So the core, if we're really going to talk about prevention and equity and all of those, we've got to talk about work and the nature of work. The fact that we have, people have to, essential workers, precarious work, multiple sites, multiple jobs, it's not new, it's not different. For us to talk about solving, addressing the problem without addressing this, for me, it's practically a waste of time. Sick time. I hear public health message, take the test, stay home until you get the result. If you don't have symptoms and you're in touch with somebody and you're concerned, stay home. Well, I'm sorry, essential workers, you don't get paid for sick time. So, you have to pay your rent. It's a message that doesn't resonate. And at the same time, we have governments and etc. who have removed sick time as a right for several of the people in precarious work. They don't have sick time. So I'm not sure where we're going if we're not talking about things like sick time and how do we have it entitled. Why do we still are not able to talk to say wherever you work, you can contribute to a benefits program and a pension plan we have the skills. Why can't we have those large plans that you can go from employer to employer and still have that? That's still missing. Housing. It has to be at least 30 years that either federal or provincial governments have invested in affordable rental. And we often quickly jump to subsidized housing or public housing. And I'm talking about working poor being able to pay rent. They used to have Canadian mortgage that used to be able to afford a mortgage of working people. So at least 30 years that we have had no investment in those areas. Short of that, overcrowding exists because you need that many people together just to pay rent. So all the conversations I hear us having around COVID data, testing, isolate, all of those I have no quarrel with. I just know we cannot be talking about pandemic, preventing wave 3, wave 4, and future pandemic without clear language of structural change. Structural change is what is required, and not terms like determinants of health. Those are great terms, but it doesn't land on me as a personal support worker doing 3 jobs in order to make rent. So we need, as we go forward, that's the kind of conversations that I would like us to see. I mean, I've been fortunate enough to be at tables where I've seen the Ministry of Health and agencies that own home care workers argue, but the workers aren't really there because there's nobody representing them. And so nothing changes. 40 years later, it's the same. My fear will be the same going forward. I look forward to the question and answers to round out some of this conversation. Thank you.
Thank you so much, Camille. You bring so much experience from so many different positions you hold. And so we really appreciate it. Joe, I will send it over to you.
Well, thank you, Arjumand. And first of all, thank you to the U of T and the School of Public Health. And I'm delighted that we have the formation of the Institute for Pandemics. And I will tell you, it's a real honor to follow Nancy and Camille and to be here alongside Professor Siddiqui. In fact, having heard from the previous 2 speakers, I'm inclined to believe that I'm not worthy of sharing the stage with these remarkable women. And I mean that sincerely. It was impressive. And thank you to Camille and Nancy for your words. I'll bring a couple brief remarks in my capacity as the chair of Toronto's Board of Health, the largest public health unit in the country, and also I can tell you as a member of the City of Toronto's COVID-19 Strategic Command team, on which I sit with our mayor as the political representatives there. And I'll bring a couple remarks in the context of our city, of COVID data, what it says, and the story behind it, and how I believe we must all demand much better of our governments. I think if you start with the City of Toronto and you look at our city prior to COVID, in so many ways, the City of Toronto was frequently listed at the top of many lists. We were said to be, prior to COVID, the most livable city in the world, according to The Economist. Wired magazine said we're the most intelligent city in the world. KPMG, for what it matters, says we're the most tax competitive city in the world. And everybody talks about that the City of Toronto has more cranes in the sky than any other city in North America. Those are top 10 lists. I guess it's good to be at the top of them. But there are other lists. And prior to COVID, if Toronto was at the top, it was for the wrong reasons. Toronto is the inequality capital of Canada. According to the United Way, the gap between the rich and the poor is growing at a more pronounced rate here than any other city in our country. In fact, 1 in 5 adults live in poverty. Toronto is the child poverty capital of Canada. According to the Children's Aid Society, nearly 1 in 3 children in our city live in poverty. And worse still, and this will not surprise anybody here, is that for racialized Torontonians, those numbers were far worse. 44% of Black children in Toronto live in poverty, compared to just 15% of non-Black children. Poverty rates in some communities in our city, prior to COVID, were as high as 40%, predominantly in racialized in communities with a disproportionate number of racialized Torontonians. And so even prior to COVID, if you argue that the test of a city or the test of a society is how well it cares for its people, how well we care for each other, I think a very strong case could be made that our city was failing. Now, it's in that context, in that overview in terms of our city, that you look at COVID. As we all know, COVID didn't create issues of precarious work or the lack of affordable housing or structural racism, but COVID has sure magnified those issues and it has exacerbated them. And so let's then translate that to our experience with COVID in the data. In our province, in Ontario, I go back to the first wave in April, when our Chief Medical Officer of Health in this province and the Premier were asked about disaggregated data and the need for race and income-based data. And their response was, we don't need it because COVID affects everybody equally. That's what they actually said in April, after everything we know, after we'd seen data in other jurisdictions. And we know that diseases have long preyed on poverty. We know that the social determinants of health, your job, your housing, it's the social determinants of health. Your race, it determines who gets sick and who doesn't, who lives and who dies. And so it was in that context, I can tell you from the Board of Health in our city, that in May, we began on our own collecting disaggregated data. The results, while not surprising, are brutal. There's just no other way to put it. They mirror what we've seen across North America. From May to September the 30th, according to our Toronto Public Health data, 79% of cases in our city of COVID are racialized Torontonians, 79%, whereas 52% of our city identify with a racial group. You break that down further, Black Torontonians, 24% of all cases in our city thus far have been Black Torontonians, whereas Black Torontonians make up 9% of our city's population. And of course, Caucasian Torontonians, who represent 48% of the city, make up only 21% of the cases. This data isn't new, it shouldn't be surprising, but my goodness, for a lot of people, it's been a wake-up call, and thank goodness. And it's, the collection of data, and I thought Nancy's presentation and the double-edged sword was so thoughtful. I will tell you that from my position and vantage point as an elected official, that collecting disaggregated data is a necessary act because it forces elected officials to either act or allow injustice to continue. You're presented with two options. If you collect the data, it's what gets measured gets done or gets ignored. And so in the context of the response to COVID, I will tell you from the City of Toronto's perspective, I will tell you that I'm proud of much of the work. I am proud that we proactively collected data and have sought to use that data not as an endpoint, but to guide and inform our response, to embed equity in our response, whether that's isolation facilities for the underhoused or outreach teams based on the ground with community-focused agencies to support those who have trouble accessing testing or resources. I am proud of our advocacy around sick leave and an eviction moratorium and income supports, especially for undocumented workers. But I will be the first to tell you that we haven't done enough. And I will certainly be the first to tell you that on the whole, all levels of government have failed on this front. We have task forces at every level of government around PPE. We have task forces to coordinate enforcement. Where's the task force on equity? We have indicators to guide when and how businesses can reopen. Where are the centrally embedded equity indicators to tell us if reopening works for everyone as opposed for just some? And you only have to look right where we are today in the City of Toronto and in the province at our second wave and the lockdown measures, necessary lockdown measures to reduce contacts and to reduce cases. But these lockdown measures have been rolled out in the same way as the first wave, without sick leave alongside them, without adequate income supports, without an eviction moratorium. And so we are on the precipice of repeating the first wave, whereby racialized Torontonians will not only be disproportionately affected by perhaps contracting COVID, but disproportionately affected by the lockdown measures that will be put in place to tackle COVID. And so, in the face of this data, I will tell you, some politicians and elected officials just don't get it. It's not their lived experience. Or they see standing up for the so-called little guy, standing up for the Caucasian small-town business owner, not the frontline worker. And worse, other politicians don't care that structural inequity is a byproduct of society and it's acceptable. And so I would just close by saying, I believe in the realm of public health, our role today in the context of COVID is the same as it's always been, to loudly and clearly make the case that to address the social determinants of health, to address inequality, is the best form of prevention. And we've always, in the world of public health, we've rolled rocks up hills for decades, writing reports, issuing recommendations. Time and time again, we've tried to roll the rocks up the hill on the structural issues of inequity and racism. But I believe that now, anybody in the world of public health, whether you are a commentator or an academic or an elected official, you have a fundamental duty to use this platform that people are listening to demand better today and after COVID tomorrow. Because there's no guarantee, if and when we beat COVID, that the public will listen to public health experts with the same degree they are today. So let's use this moment to tackle inequality. Otherwise, we will have failed, not just in our COVID response, but in our collective duty. Thank you very much.
Thank you so much, Joe. That's really, really helpful. So as you can all hear, there's some very interesting ways into this problem that each of our panelists have suggested. And I'd love to have a conversation now between the three of you around what I see are some of the sort of critical nexus of issues that people have identified. And as I do that, I encourage people to go into the Q&A and ask questions that, again, we will use as the basis for the audience participation segment after we have a discussion with the panelists. So let me start by asking you a little bit to elaborate a little bit on the issue of data. This, Nancy, as you can tell, is sort of new for us. This is something that we are just embarking upon in Ontario. So as Joe said, initially there was resistance, and now there is some race-based data collection. But unlike the United States, there's a lot more contention about that data collection. Not that there's none in the US, but it is certainly something that is widespread and it's not new. The sort of notion that race is asked in the healthcare system, in the labor market, et cetera, it has become sort of something that people in the US at least come to expect. So let me ask you all a little bit about that data question from a couple of perspectives. One is this issue that, as many of you brought up, what we're seeing in the patterns aren't surprising, right? It's not surprising. We've seen racial health disparities time immemorial. And so one question is, what becomes the value of that data? And all three of you alluded to it to some extent, but if you could talk a little bit more about how you see the value of that data in the context of the fact that it's not new, that we've been in the US, for example, doing this for a long time, and that double-edged sword, Nancy, that you mentioned, the other side of that sword, I think there is a loud concern in Toronto that what you may see is stigmatization of communities based on that data, misuse of that data in various ways. And so if you take that balance of collecting the data, reporting on it in the context of the fact that we've been there, done that with other health outcomes, and not seen much progress, is it worth it? Is it actually worth it, given that there might be some considerable downsides to it? So maybe I'll start with Nancy and then open up to Camille and Joe as well.
Thank you for that question, Arjuman, and I'll just keep it very brief. I think that a key lesson to draw from the US is that data, for example, on the various permutations of what gets called race ethnicity are never sufficient by themselves. They have to be contextualized. You have to bring in exactly all the kinds of social and economic factors that both Camille and Joe were talking about. To have data only presented in relation to race ethnicity leaves it to the interpretation of whomever, and also continues to treat it as if it were an individual characteristic. It's not. It's membership in a social group. And you have to ask how those social groups got defined and why they got defined as they did, by whom with the power to define them. So I think one key thing is that if you want to avoid mistakes that you have in the US, it's the mistake of being able to only present data of race ethnicity, so-called, on its own and not contextualize in the lives of individuals, but also the communities and the economic structures. So for example, if you want to talk about, for Toronto, to bring out, well, what is the precarious worker situation? And what is the housing situation, affordable housing? What are the policies among people who do not have sick pay as part of their jobs? What do you see as COVID rates? Is that also racialized? Because, for example, occupational health data clearly show that even with the so-called same job titles, you will still see racialized inequities because people actually have somewhat different functions in the way that they're allocated. So I think that those become the challenge. And if you're starting building a scratch on a newer platform, then don't do the things that in the US have been baked in since 1790. So that's point number one. Point number two is that data by themselves, there aren't ever data by themselves. Somebody created a database, somebody paid for the data, somebody has a computer these days, somebody, there's never data by itself. And again, they never speak for themselves. But data can be crucial if done well to understanding if things are getting better or worse, which matters for purposes of accountability. And that's not something that can be assessed only qualitatively. But I was just at an event this weekend, or not at an event, you don't go to events anymore. I was watching a Zoom video, Zoom event with Ayanna Pressley, among others, who's one of the very progressive Congress people from Massachusetts, African-American, who's on climate justice and racism and what to do. And she spoke very persuasively about the power of stories and data. So she tells stories to get the points across, but she backs them up with all kinds of data to make the case of who is being harmed, where are things getting worse, where are things getting better, and whose feet need to be held to the fire. So I think the point is not data for itself as a pristine object to venerate. It's data to use to make a difference for health justice.
Absolutely. Thank you. Camille or Joe?
So my response is that, I've been pushing this ball uphill for quite a number of years. And I too very rarely talk about racial data. I talk about equity data. And equity data covers a wide range of information pieces like income, household, number of people supporting the household, sexual orientation. All of those pieces come together in the information that's required. And we get stuck on data collection. And for me, that's not the goal. It's a means. What it is, where we're aiming for, is the disparities and the reduction of the disparities. That really is where we're going. And the value of that is not only to hold, in the case of what I'm more familiar with, healthcare accountable, is for the community themselves to have that information. So the community themselves can begin to hold, we're taxpayers, to hold government and organizations accountable for maintaining those disparities that exist. And then we have concrete things that we really need done and we can actually measure it. So I think equity data, or some other term we can come up with, is the goal of collecting a range of data and reducing disparities, naming it, calling it, identifying it, putting it out there, reporting it, publicly reporting it, giving it to communities so that communities have access. Right now, if you don't have a PhD and a doctor in ISES, you can't get access to the data. And yet it's your community and you're a researcher in a community that need that information. So those are all the pieces that I think need to be addressed. Data governance is a key next step for me.
Great, thanks. Listen, sometimes you're a researcher and you still can't get the data, but that's a different story. Joe.
I would just add 3 brief points to this question. I think the first is that if we start from the premise that it's a postal code, not a genetic code, that's the predominant driver of health status, then it needs to be the right data collected. So looking at housing, at income, the type of workplace conditions you're living in, you need to ensure that it's the right data that is collected, as Camille mentioned. I think to ensure that how that data is collected and shared, that must be done in deep consultation with communities to mitigate against the risk of stigma in the misuse of that information. But I will say as an elected official that in the absence of data, there will be no action in speaking to its importance. Assuming you've collected the right data sets and it's shared appropriately. I can tell you in the context of COVID, if it wasn't for the socio and the income and race-based and housing data that was shared, if it wasn't for that, we would continue to have governments telling us that the problem is private social gatherings and people not wearing masks. They would still be saying that, as opposed to overcrowded housing conditions, unsafe workplace environments, frontline workers without sick leave or income supports. The data has exposed that because the elected officials we've got, that's not what they believe.
I'd like to jump in on one thing there, which is that what this conversation is bringing out is that, again, it's not the data by themselves, it's the narrative that is used. It is the framework that is used to illuminate the data, to say what is there and also what is missing. Data never travel by themselves. They never sit anywhere by themselves. They are produced and interpreted by people. So that narrative, in the US at least, there's a lot of work that's called, around so-called, I guess, narrative justice. There's about changing the narrative. There's about bringing out the histories that need to be brought out to understand why do certain groups live where they live under the conditions that they live, and not just why them, but actually who's benefiting from that. What have been the structures? So for example, the work that's being done in the US now, beginning increasingly, is the revelation of the 1930s historical redlining that was the government involvement in creating racial segregation throughout the United States and driving it much further than it had been already. And that there's actually now new work to help try to figure out where that's going to move in terms of accountability structures. That it's not just that people choose to live this way, because you end up with otherwise the narrative becomes lots of individual bad choices. I mean, the mainstream dominant modes of thinking in health and in public health are biomedical and lifestyle, and victim blaming, they get there faster than you can even shake a tail. So it's really critical that if you're going to bring out the structural change, the structural determination, that has to be part of the very narrative and the data that go together, and the words and the images and the ways to produce the maps that actually show that, so that it cannot be individualized, it cannot be decontextualized, but instead must be historicized and contextualized, and then say, whoa, it's stagnant, these problems, they have to change. Who steps forward to be able to push that forward?
Absolutely. Thank you all. That's super, super helpful. And we have an audience full of people that I think can take this information up. I'm going to move now to the questions from the audience. And the first one is about what people outside of the government and outside of academia might do in concert. How can people become allies and help to make change when they are individuals in the community, when they are parts of foundations or businesses, when they are community leaders of various sorts? How can they participate, and what have you seen in terms of successful ways that they sort of engage in these topics? And maybe I'll ask Camille or Joe to start by giving the Toronto examples.
It's an interesting question, because some of the powers that we have is vote. It is calling your counselor. It is participating in conversation. So for example, when we see a government making a decision such as eliminating sick time. So instantly, all of us should be aware that our essential workers and everybody else, we get sick time. How come those people don't get sick time? What are they supposed to do when they don't get sick time? Those are some basic things that's just out there that most of us have, but we don't recognize that others should have it as well. And so, just as citizens, how do you speak up about that? How do you vote or let your candidate know this is important to you? How do you let them know, well, I voted you in, but that's not okay for you to now eliminate sick time from a whole group of people? So, I think people just need to get engaged and understand that they are part of the society. And if you're not part of the solution, you're part of the problem. And you don't have to always carry a placard, but you do have agency, you do have currency in your work, in your vote, in your club, in your membership to all your various organizations. And I don't think it should only be us Black people that have to solve this problem, because it's not, we didn't create it and we experience it and live it, but others benefit from it. So recognize those privileges as well.
Thanks, Camille. Joe, anything from your side?
Well, I'm one who believes that change comes from organizing, and the form of organization can take many different places. Can take place in many different places. So whether it's as an activist in your community, or with an issue, a specific issue, or with a specific organization, or whether it's using your personal agency in the issues you choose to focus on, and how and where you share it. And so I believe change comes when we organize and fight for a different future. I will tell you that where I think the question of what can we do, where it speaks volumes, is going to be in the discourse as a vaccine is ultimately rolled out and available coming out of COVID. I think there is going to be a large and big push to simply return to the status quo, to finally get back to the so-called normal. And if all we do is return to that unacceptable, unequal normal that existed before COVID, we will have collectively failed. And so I think for all of us, in every setting in which we organize and operate, in our communities, in our workplaces, in the organizations we're part of, coming out of COVID to demand a new normal, to address the inequities that COVID exposed, that is our collective task. We cannot simply beat COVID to go back to where we were before. And I think all of our collective agency needs to go towards the future and building, that tagline, build back better. Well, it's real, and we need to work for it.
Thanks.
Arjun, can I, sorry,
Yes,
can I just suggest that, because all of what Joe said and I've been trying to say, I thought was excellently done in an article by Dion Brand on narrative, reckoning, and the calculus of living and dying. That there is no going back to normal, because there was never any normal for most of us. And so how do we recognize that? So I just wanted to, because I reread that in preparation for this, and I thought a lot of the stuff we're talking about is well said in that article and is worth reading.
That's great, thanks. And actually, Camille, I think I've shared the 2 links you provided, including the one to Dion Brand's article in the chat, if people want to look there. Nancy, did you have anything that you wanted to add on the matter of how people can engage?
I mean, there's just so many different ways as a member of your society. So, if you're in a workplace, if you're in a community, I mean, there are always groups that are trying to move forward the work on equity. And so you have to look for that and find ways that make sense for who you are. There's no one right way to do it, but there's a lot out there. I can't speak, obviously to the Canadian situation, but I know, just even in Boston, there is a plethora of groups, and there's pushes and there's work to get the legislature right now to extend the eviction moratorium, to deal with more of the sick pay issues that are being discussed, to extend protections to undocumented workers. I mean, there's very active organizing, and there are lots of ways. And it just, even for people to take the step of just even calling their, representatives is like important. I mean, obviously in the US, it's been all complicated by being bound up in this past election. So there's been an awful lot going on, shall we say. But I do really want to also underscore the point about the not going back to normal. I was, the people that were members of the Society for Epidemiologic Research were sent a New York Times survey that just went out, asking us about, what we're doing with Thanksgiving, and then also like, what are we going to do when we get back to normal? So I wrote quite the screed about there's not going back to normal. There's dealing with all the things that COVID has exposed. There is dealing with climate crisis. We are not going back to normal. Suffice it to say that that wasn't one of the quotes included when the New York Times reported on how people.
I was going to say, I missed that in the time.
But I just think that that gets back to this idea of narrative, and that's already out there. And people therefore need to be actively mobilizing now in writing, in visual performance, in whatever it takes to say, nope, not back to normal, because one, people are going to continue to suffer needlessly because of that. And two, this planet can't take it. And that means three, none of us on this planet can take it.
Fair enough. Thanks, guys. So the next question is, I think, a really apt follow-up, which is that, okay, so let's accept that we're collecting data here in Toronto. Let's accept that there's no going back to normal. Let's accept that this has exposed a bunch of things or highlighted them or what have you that need to be done, and we all agree on that. There's two elements to this that I think are important to push. One is, what does that mean for what we need to do? So what does that mean for structural change and the timing of structural change and the urgency of it? And what does that mean for holding accountable people in government to make those changes? So in other words, if now we have the data that we didn't have before, if now that's assisting in creating a narrative to bring to policymakers, now what? So what should we do? And I think Camille, in your talk, and Nancy and Joe, you also addressed this. There are some structural changes, including around housing and so on, that are urgent. But what would you suggest we sort of do? What's urgent, and how do we make sure that people are accountable to do it? Joe, maybe I'll start with you.
So if I'm a joyful guy. I believe, if you miss the joy of it, you miss all of it, is something my father always taught me. So I'm a joyful person, but I would not tell you that I'm optimistic that necessary change is going to come out of COVID. And that's because I believe that the entrenched interests and political discourse right now is not receptive to transformational and structural change. But it is what's necessary. So what needs to come out of this? I think in the conversation we've had, data, the right data collected in the right way, needs to continue, disaggregated data to be collected and shared to hold decision makers accountable. I think we must come out of this continuing to collect it. And then we need to fight like hell for a universal basic income. We need to fight like hell for an affordable housing strategy that's actually going to build housing where it needs. We need to build a publicly funded childcare system that's accessible and affordable. I mean, the list goes on and on and on. But I guess my main point would be that we're going to have to fight for this, because there's going to be an overwhelming demand to just forget COVID and go back to the way it was and praise all the people who made the hard sacrifices on the front lines. Thank you very much. And so we need to continue to collect the data in the right way to hold those in power accountable and to use that in order to mobilize and expose the truth. But we're just going to have to fight really damn hard and organize to address these inequities. And listen, it's same as it ever was. Change doesn't happen overnight. It doesn't come easy, but we continue to work for it.
Yeah, Camille.
I would say two things. Although I have been a champion for data and data collection, I think it's important that communities right now begin to organize around what I refer to as data governance, which is a mechanism by which they have input and say and control of the data. interpretation of the data, monitor misuse of the data, ensure that the data is not sold into the private sector. You know, like that double-edged sword, I think, is key. We really need to recognize that other side of that sword. And instantly, that for me is the work of the various communities to make sure that they get control of that immediately. The second piece is we're going to have to organize and resist, because right coming out of this, there is going to be this overwhelming, first of all, backlash to Black Lives Matter. And by, you know, we have seen it every time you go, there's a reaction. We need to expect that reaction and be prepared for it. But also there's going to be this heavy push for economic recovery and what we can afford and what we can't afford. And so the work will be in the organizing to hold fast to the importance of the childcare, the importance of wage guarantee, the importance of the job and improving work. All of those things that we value and know if we don't do the next pandemic, it's just going to keep calling us, is the work to be done. But I think that will happen in a context of some real backlash and some real push to say we can't afford, we spend too much money over COVID, we've got to recoup that money. And you can hear that already emerging. So, you know, we know that's coming. So how do we work and organize to go through it and still keep the agenda going?
Absolutely. Nancy, any thoughts?
So again, there's not just one single way. I completely agree that in the US, there already is backlash against Black Lives Matters. And then there's also been incredible mobilizing. I think that there's I'll just respond to two different points of the many rich points that have been brought up. So one is that on the thesis that quote unquote, we, whoever that we is, can't afford to fix these problems. There's just been a very useful report put out by the Institute of Policy Studies and others in the United States, which is titled Billionaire Wealth versus Community Health, Protecting Essential Workers from Pandemic Profiteers. And it goes through what they call the dirty dozen, and it looks at them, whether it's the Walton family with Walmart, whether it is Jeff Bezos and Amazon, whether it is the Tyson Food Industries with the meatpacking plants, that they have been reaping huge amounts, some of them because their industries became effectively single industry because the competition was ruled not as essential. That happened with Target. And they've been cutting back on sick pay. They've been cutting back. They did these tiny bonuses for people with hazard pay and cut back. So I think that there's work to be done about exposing who has really been making a fortune off of this pandemic and actually undercutting their workforce and their workforce health and safety in the process of that. And I think that there's a real room for moral shaming to lead to change, and that also one of the policy proposals they put forward, for example, is a pandemic billionaire tax, which is no pandemic profiteering. And I think that may have some resonance. So I just think that the idea that there's not money is not actually looking at what has happened with where there is money, where the pressure in the United States has been, again, from about the opposition to lockdown has been predominantly from the standpoint of preserving the businesses, not the people that actually work at them. So that's, I think, one really important thing. The other thing that's, again, in a US context, which again, I have no understanding of how it works in a Canadian context, is I have become increasingly aware that with the work of public health, to be ignorant of the rules of the game is not so helpful. The structural rules, and to make real what it means to talk about structural whatever. So for example, how is gerrymandering, which has been escalated over the past 2 decades, affecting who the politicians are even? Because there was, and that was brought to me by one of the first climate strikes that was here, 2 falls ago, where it was like the politicians need to listen to the data. And then that sort of begs the question of, well, who are the politicians? And then where's gerrymandering fit into that? Or the rules that are about right now, like in the United States, around what has been, beyond flagrant attempts to have voter suppression. Where if you're going to have democratic governance, does that mean actually listening to the demos, the people, or not? So I think that then making the public health links to, if you're going to have accountability and be able to do something about who is actually even there to try to change the structures of government, it's multifaceted. There's a part where we come in public health with very specific expertise. It does matter to know that COVID is spread by air. It's very different, for example, than HIV/AIDS. It's very different, for example, even in infectivity, than measles. I mean, you have to know there are things you need to know about the biological, biophysical world we live in, what is happening with different types of communicable diseases, what is happening with different kinds of pollutants, how they travel. There is room for technical knowledge, but technical knowledge at the service of whom? And I think that's just a really important part. And then the public health people that are listening to this, it's how do you engage? The question I always ask myself and my students is, who do you want to do what differently because you've done this piece of work? What are you addressing as a gap in knowledge that people are actually calling out as a gap in knowledge that's needed? It's not like you just think everybody knows everything already, because that's actually not true. That's not the world we live in. There is knowledge to gain that can be used to make a difference. And it certainly makes a difference to know that there have, for example, been billionaires just beyond profiteering off of the pandemic. That gives a new focus for some of the discussions about where's the money going to come from to deal with things like sick pay and much else.
Great, thanks, Nancy.
Arjun, could I add one brief thing?
Yes, please.
It strikes me that decision makers care a lot about public health when they're seeking our advice on how to respond to a crisis in real time. But in the world of public health, we're often ignored when we're talking about prevention in the long term. And so for everybody tuning in today, for everybody in the realm of public health, I do believe it's incumbent on us, whether you're a professor or a civil servant or an employee in the healthcare field, to use this moment right now, to use whatever agency and profile you have to demand real structural change and solutions. Because if all we do in the public health world is use this moment to give front page advice on how to respond to COVID today, we're not going to solve the structural inequities tomorrow that COVID has exposed. And that's for all of us in the public health world, to use this moment and to not miss this opportunity when people are paying attention to us.
Thanks, Joe. And actually, it's a perfect segue into the next question I have for you. And that is about understanding what the deal is. Why haven't we seen more happen, or would you even characterize it that way? So, we have an anti-racism strategy, a municipal anti-racism strategy. We have, now we have data. We have had an inkling that this is happening for a while. So early in the pandemic, we even had neighborhood level data. What is your sense of what the roadblock is, or roadblocks are, in making more progress? Or again, would you even characterize it that way?
And I'll be brief to, I think for some, politicians don't get it. I think when we look at our city, in the city of Toronto, when we look at our province and country, the political class is still disproportionately higher income and Caucasian. It's people of privilege like myself. And that absence of lived experience is reflected in policymaking. And so I think in part politicians don't get it. It's not their frame of reference and it's not their lived experience. And worse, I think others just don't care that the power inequities, the systemic inequities, are part of a capitalistic society, and that's an acceptance that people make.
Fair enough. And I might add, even worse, it may be in their interest not to care, which is the worst of all scenarios, but a very real possibility. I'm going to just end the conversation with the three of you now by thanking you ever so much. You shared so much of your work, your lives with us, and I think we're all better for it. So thank you very much to Nancy, Camille, and Joe for joining us today. I am going to throw the microphone over to Dean Staney Brown for some final remarks.
So first, thanks. Yeah, first thing I need to do is thank Dr. Arjman Siddiqui for championing this and organizing this and making sure that we've had such a good discussion today. Dr. Krieger, thank you for joining us from Boston. It's probably an easier flight this way, but it's would have been wonderful to have you in person. Mr. Cressy, thank you for speaking today as well and bringing a great perspective to the panel. Ms. Camille Orge, I spent a lot of my life thanking you, and I'll do it again now and say thank you, and thank you for being part of the school. Look, I'll just make a couple of three short comments and then close by thanking people again. The first is that public health is an applied science, right? I don't think we should ever get away from that. And one of my colleagues has taught me to say that there's nothing so practical as a good theory or so useful as a good theory. So everything we do, even whether it be developing theory, or testing theory, or working through data, has to be with the goal of having action. And when we get into discussion about the data, as Camille says, if data governance is the way that we need to get this going and get this, make sure this has impact, I think that's what we need to do. I do think, though, that we need to make sure that when we talk about how our health system is performing, equity needs to be a dimension that we actually look at and evaluate ourselves on. It's something we've accepted in principle and failed in practice for a long time. Second, I maybe want to point out that, we're living through a pandemic right now, and the impact of the pandemic is inequitable. The impact of the recovery may be even more inequitable and have a longer tail. And as we start to think through this, we will just put ourselves at even greater risk of the next pandemic unless we deal with that inequity. There's ways we can respond now that will help us, but unless we deal with the structural factors, we'll never really get to anything that we can mean is prevention or anything like that, and prepare ourselves for the next one. And one of the things I want to note is that there's lots of things that we could be doing. I think we could be having report cards. I think we could be having scorecards. I think we could be making sure that every time we point to a problem, we advocate for a solution as well. But a little bit is that we'll continue this lecture on an annual basis. And with that, I'll maybe close by saying thank you to Sabina Vora-Miller and the Vora-Miller Foundation for supporting this, making sure that we could actually do this. This is the first time I've been in any room with close to 800 or 900 people at the same time. So I'm really grateful that we're able to do this. And I'll just turn it back to you, Arjman, with my thanks again.
Thanks so much, Steny. Just a final thanks from me, again, to the panelists and to the audience for joining us. I hope that we take up the call that we've all sort of unpacked here, the panelists and the audience, and move forward with this for Toronto. Nancy, and best wishes for Boston and the US as you move forward with your work. Thanks so much, everyone. Take care.